Hello and welcome back to The Path, the podcast from Lifestyle RX. Joining you again this week is myself, Dan, and Dr. Byrne. How are you doing today?
Doing awesome.
Excellent. So our topic for this week is we're going to start talking about the science of type 2 diabetes reversal. So I guess let's jump right in. So maybe to start off with the big question, we talk about type 2 diabetes reversal a lot. Is all type 2 diabetes reversible? Just some people's? How does that work?
Yeah, so at this point, not all type 2 diabetes is reversible. And so one of the first things we do when we see a patient in the program is we try to figure out what that person's balance is between their pancreas's beta cell capacity to produce insulin and the degree of insulin resistance that they have. Generally speaking, if we see a patient's got kind of high pancreatic function or normal pancreatic function, and it's really insulin resistance that's pushing them into type 2 diabetes, then that's reversible, as the insulin resistance, as we talked about on the first episode, is really tied to the fat in the liver, and we can get rid of the fat in the liver. If the person's got what we call pancreatic beta cell deficiency, where they're just not producing a lot of insulin, these patients are probably they're less likely to achieve true remission. So we can get blood sugars controlled through lifestyle behaviors and medication, but true remission is probably not the right term for it. So we usually, for those people, we say, look, the goal for you is to have, optimized blood sugars on the least amount of medication possible.
Okay, cool. And then you talked about pancreatic beta deficiency. Why would someone actually get that, or why would they have it?
Yeah, so great question. Essentially, there's three reasons. And so one is it can be the byproduct of just a long course of type 2 diabetes. And so, we used to kind of call it that the pancreatic beta cells were quote unquote burnt out. And they've been pumping out a lot of insulin, and gradually they lose their ability to pump out any insulin. And we do see that. But what what we're learning now, and it's kind of interesting, what we're learning is it's not so much that these cells are disappearing and dying. They're actually de-differentiating. So, cells specialize, and they differentiate into cells that can produce insulin. They actually lose that, and they de-differentiate. One thing that so, and that part seems to be some of that they can re-differentiate back. So for the long-standing diabetes, there are some people that definitely kind of qualify for that, but it doesn't preclude remission as a goal for us, right? We know that people, if it's within the first 6 years of the diagnosis of type 2 diabetes, much more likely that they'll achieve remission. But beyond 6 years, we've had people 20 plus years that have been on high doses of insulin that eventually we get off of insulin and can see a full remission for. So we just don't know. But nonetheless, that is kind of one of the categories. The second category is genetic, and there just are people out there, and there are a variety of genetic kind of variations where they just don't produce a lot of insulin. And so these people will often have they have some insulin, but they don't have a lot. For these people, it's very important for them to understand that, realize that, and gear kind of our lifestyle strategy around the fact that they've got some insulin, but not a lot. And these people will do really well in our program. The third category, and it's actually what our case of the week is what we call autoimmune. Basically autoimmune pancreatic deficiency. So it's an immune process very similar to type 1 diabetes, where antibodies attack the pancreatic beta cells, and people over time lose their ability to create insulin. So that's the basis for it. What's interesting is that the long-term kind of prognosis or history for these people isn't particularly well known. And in fact, kind of the more that we kind of learn about this, it seems to be a variable course. There's some people who, once the antibodies hit, their pancreas function really drops down precipitously, and it's much closer to what happens in type 1 diabetes when it's diagnosed. There are other people that seem to maintain a certain amount of, essentially maintain a certain amount of pancreatic function for quite a long time. And so again, important for us to understand, is this happening or not happening? And then we diagnose it by ordering tests, so GAD antibody tests, um, and essentially about 90, for autoimmune, there are some other antibodies, but 90+% are covered by that one antibody, and that will help us know, okay, this is an autoimmune process. Um, there is a whole line of thinking around autoimmune where looking at other factors like inflammatory factors, gut gut health, digestive factors, may be able to modulate that autoimmune process.
Mhm.
Again, we don't really know there. In our program, identifying them, helping people get a really good strategy to make the most of the insulin they do have, and then following along closely just to be sure that they continue to maintain optimal blood sugars over time is really the approach that we would do.
Yeah, so for those that have the genetic or the autoimmune um, version, obviously making the lifestyle changes is still super important for them. It still helps it to, even if it can't fully get reversed, manage it, right?
Yeah, it was interesting when we first started doing the program, and we'd identify people in this category. Um, what's interesting is many of them have been seen by their endocrinologist for years and just been treated as type 2 diabetics, but they don't always fit the profile, right? So often these people are lean at a normal BMI, and their blood sugars really bounce around a lot because there's not a lot of insulin there. Um, so discovering kind of diagnosing this when we first started, we thought, okay, well, these people probably aren't the right people for the program because they don't really have insulin resistance, and we're
Hmm.
to be talking about losing weight and reversing insulin resistance. What we found was, as people with this condition started to work with us, um, the lifestyle behaviors were actually really important. It was just a different goal, right? So their goal is to eat in such a way that they didn't spike their blood sugars and maintain very even blood sugars. And so kind of our principles around nutrition are actually completely applicable for this population. And the way that we use continuous glucose monitors to help people understand kind of which of what we call the yellow light carbs they can tolerate, really is a key thing for them.
Hmm.
The other thing is exercise in this group. Since there's not a lot of insulin around, exercise and the movement of muscle can get glucose into the muscle without insulin. So really, really handy for that behavior as well. And then, of course, sleep and stress, actually have a higher impact when there's less insulin around
Hmm.
because it's just more ability to kind of knock you out of blood sugar control. So in fact, what we've learned from working with these people is that you know um, the at the how level, kind of how to do these things, that the behaviors all apply. It's just kind of why you're doing it, and the purpose of what you're doing is a little bit different. So it's just a different goal, and so we kind of let go of the word remission for these people, but what we really kind of say is, look, you definitely can get really good control with minimal medication.
Okay, so it's the same steps, just with maybe a little bit of a slightly different goal. And that's something that when we get those personalized reports that we give out, that's where you go into detail about what kind of this people have, and kind of really get them to understand what they got going on, right?
Yeah, it's foundational to our approach that we want to help people understand why they've developed type 2 diabetes. And with that why, we can we can start to focus on what to do and how to do it. If
Mhm.
you don't understand that why, it's very difficult. And for example, just like I said, originally we didn't think that we could work with it, that it made sense for people with this degree of pancreatic deficiency to be in the program, because their why was different than why they're developing type 2 diabetes is clearly very different than somebody who's got is on our insulin resistance pathway.
Mhm.
what we learned was that why is actually very personal, and so we could do that within the one-on-one consultation process, have them understand that they recognize that they're in the group, and the reason why they have diabetes is a little bit different than what other people are doing.
Hmm.
And with that understanding, then they're able to benefit from the program.
Yeah, definitely. Okay, so we're talking about the pancreatic beta capacity and the insulin resistance, what is the actual method that you as a physician would use to figure those things out for a patient, and actually, so you know, like what those numbers are and how what those are actually looking like?
Yeah, so this is really key. So we order something called C peptide, and so when insulin's created in the pancreatic beta cell, it's created as a prohormone, and there's a peptide that gets cleaved off, cleaved peptide or C peptide,
Hmm.
um, and so that circulates in kind of equal proportion to the insulin. So it gets cleaved off and goes
Cool.
into circulation. Yeah, and insulin's actually super volatile. It's absorbed really quickly, and the body disposes of it very quickly. Whereas the C peptide is actually a little bit smoother in terms of its levels over time. Also, if somebody's taking exogenous insulin, so they're actually taking insulin as a medication,
Hmm.
that would confuse us if we were just measuring insulin.
Yeah.
So measuring C peptide is great because we can actually see, okay, it gives us a measure of how much insulin is being produced. So we take that C peptide level and then we compare it to the glucose level at that point in time. So when we do the blood draw, we do both the C peptide and the glucose level, and we do this usually as a fasting test, and then we run it through a little piece of software that we've licensed from Oxford called HOMA-IR2, which basically is a nonlinear equation that calculates how hard the pancreas is working, so what beta cell
Mhm.
percentage you have, and then what degree of insulin resistance there is. So it's a very, very good measure of insulin resistance from a from a hepatic standpoint, from a liver standpoint. Um,
Mhm.
and it very much gives us that understanding. Some of the that tells us that that this person's not at a baseline level when they're fasting.
Yeah.
They're either producing a lot of insulin, normal amount of insulin, or not very much insulin, and that insulin's either facing no insulin resistance or it's facing a very high degree of insulin resistance. And so we see a bunch of patterns with emerge from that. Um, you know, One of the things it doesn't do is it doesn't give us kind of the dynamic response to meals, right? So when we're
Mhm.
thinking about blood sugars, we always need to think about, what's the blood sugar response to the food that we eat, and what's the
Yeah.
blood sugar response when it's just the liver that's making the glucose.
Yeah.
And so this gives us a very good indication of what happens when the liver is kind of in charge to make the glucose. It doesn't give us that dynamic response. Um,
Mhm.
so that we tend to in our program rely much more on people using continuous glucose monitors to see what their response is to various meals. Um, some of it we don't need to even test. We know that if you drink 32 ounces of Coke, we know that
Yeah.
you're going to overwhelm your system and spike your blood sugar.
Yeah, for sure. Yeah, I always thought that, when you first explained the C-peptide to me, that was, like, the coolest thing ever, that, like, there's this, like, little signal that the pancreas leaves around knowing that you can use to check how much insulin it actually produced, like, that's just something you would never think would be a thing, but it's actually just a really cool thing.
Yeah, it's an interesting little quirk in it, and it's very, very helpful for us to be able to standardize on.
Mhm.
And so it gives we otherwise, if they were on insulin, we wouldn't have a measure there.
Yeah.
Um, and it's really helpful because we'll see people come into the program that are taking insulin, and we'll actually discover that their pancreas is producing a fair amount of insulin on its own, and so the insulin is not purely necessary, right? If we can
Mhm.
get rid of the insulin resistance, then they may have enough of their own insulin to actually control their blood sugars.
Yeah, and like we talked about last week, having more and more insulin is obviously not helping the problem with getting moving backwards down the scale, right? So being able to
Yeah,
reduce that is
one of the things that you see is high levels of insulin produces insulin resistance in and of itself. It's like any kind of, anytime you have a molecule and a receptor, if you crank up that molecule, then the receptor becomes a little bit resistant to it.
Hmm.
You can think about it, as almost like it's tolerance. It develops tolerance for this. There's a whole line of thinking that, which comes first, the insulin resistance or the high levels of insulin, right? And so
Interesting.
we tend to, in our metabolic health progression, emphasize the response that, as you get fat kind of in the cells of the liver and the muscle, that there's resistance, and then the pancreas compensates by increasing the amount of insulin. There is a whole line of research and there's a debate on this. It's kind of the chicken and egg debate. And I think the reality is, if you independently have high levels of insulin, you'll develop insulin resistance as a result of that.
Yeah.
Uh, and then if you have if you develop insulin resistance, you will compensate by having high amounts of insulin. And so, it's like a lot of things in medicine. It's a little bit bidirectional. And I think for us, what we look at from a behavior standpoint, the most common reason why people are walking around with high levels of insulin is because they're consuming high levels of refined carbohydrates that require that amount of
Those
insulin
insulin. Yeah.
to store it, right?
Yeah. Yeah, so you might have already touched on this a little bit, but when we are talking about the metabolic health progression like we spoke about last week, how does that fit into this puzzle that we talked about here with the insulin resistance and the pancreatic capacity? How does that all fit together?
Yeah. So what we're trying to figure out for the individual is okay, why did type 2 diabetes develop for them? So at that broad stroke, we're going to be looking at it. Is there a degree of insulin deficiency? Is there a degree of insulin resistance, or is there a combined kind of picture?
Mhm.
And this is where there's a whole bunch of very, very interesting work that's been done. It came out of Sweden. I think 2018 was the first paper actually subtyping type 2 diabetes.
Hmm.
Anybody that practices and anybody that attends one of our groups knows that people are really different here, right?
Yeah.
There's
Yeah.
different ages, there's different body weights, there's different kind of levels of blood sugar control and so on. So they're clearly, it's not really one disease; it's a pattern. And so when they do some research looking at this, there's five subtypes that have emerged, and those five subtypes, while we don't spend a lot of time telling people kind of this is what subtype you are, as a physician, we're actually detecting these patterns because there's slightly
Mhm.
different kind of approaches to these subtypes. And so this is kind of it's helpful for us as we get this data around where the pancreas function is, how much insulin resistance there is, to start to understand, well, what's the natural progression for somebody like the person in front of us.
Yeah.
So first thing I do is I'll kind of do that broad categorization of, is this truly an insulin deficiency problem or is it an insulin resistance problem? The HOMA-IR2 gives me that. And then I'll look a little bit deeper, if they're insulin deficient, is there any degree of insulin resistance?
Mm.
Because obviously if there is some insulin resistance, then the insulin that the person does have or the insulin that they're taking isn't going to go very far because they've got this insulin
Yeah.
resistance. So that part's still reversible, and we're still going to address that. If there's no insulin resistance, purely insulin deficiency, then we kind of try to categorize, as I said, is this the autoimmune process or is it another process? So those are kind of the first two subtypes, just autoimmune insulin deficiency versus just severe insulin deficiency.
Yeah.
The third subtype that we see is where it's called severe insulin resistance. So, in what you see there is actually incredibly high levels of insulin, and so these people are
Mm.
very, very insulin resistant. They actually generally present with diabetes quite late, and I kind of liken these people to that they've got a super pancreas. Their pancreas can pump out a lot of insulin,
Yeah.
and so in our program, they predominantly show up as pre-diabetic, and they're heavier, so their BMI is higher. They've often kind of had weight issues, for a long time with normal blood sugars, and not understood that. And what's really happening here is because of the degree of insulin resistance, they're producing so much insulin, and the insulin's a storage hormone for energy. They tend to get really caught in that vicious cycle of insulin resistance and weight gain.
Hmm.
Um, I literally had people who, when I explain kind of that, their pancreas has this incredible ability to produce a lot of insulin, and we often see that their beta cell percentage is over 200%, right? So
Wow.
they're producing, just phenomenal amounts of insulin. And when you explain what that's doing in their body in terms of weight gain, and in, they're I've had patients that actually have cried because it's the first time they've actually understood their body.
Yeah.
And so, you know, again, I think understanding the why is so important. For those people, we're not that concerned about blood sugar because they got so much insulin around. They're actually controlling the blood sugar pretty well.
Yeah.
Really, what we're trying to do is doing everything we can to try to lower their amounts of insulin. So, um, the dietary principles become really, really important
Hmm.
right away for them. And the other thing that if we can get them to, if we can get the fat burning started, we can get some momentum.
Yeah.
That population, that subtype sometimes is difficult to get started with weight loss. And so occasionally, we'll see people really struggle with that weight loss just because there's so much insulin in getting any fat burning.
Yeah. Yeah.
And occasionally that's where, being more aggressive and using, something like a semaglutide or, a brand name Ozempic,
Yeah.
can be helpful for that particular group, a little bit more helpful. Um, or we can do kind of more intense one-on-one nutritional interventions, similar to what they've done in the direct program, where they really reduce calorie intake for a while.
Mm.
That being said, most people with that third subtype actually unlock their weight loss during the 12-week process, and it's a game changer. And so
Yeah.
so generally speaking, we can do this with behavior for the third subtype. The fourth subtype that we see is what we call moderate weight related insulin resistance.
Yeah.
And this is what's become the epidemic, right?
Mm.
In our society. And really what we're seeing here is just, the average person in kind of Western, well, it's not even Western countries anymore. It's just countries. It's just,
Yeah. Everywhere.
gains about a pound per year on average from age 18 to age 50, and all of a sudden they're 30 pounds overweight, and that
Yeah.
30 pounds pushes them often to a BMI of like 32 to 34. And at that point, they've exceeded their personal fat threshold, and the whole
Yeah.
metabolic progression that we've talked about on the last podcast, it it just really follows. And so for these people, the 4+2 just works incredibly well. And so we generally don't need anything outside of just doing the 4+2 program,
Hmm.
uh, and they start to lose the weight. And as they lose the weight, their insulin levels come down, and it kind of everything kind of pulls back pretty easily. The fifth population is what they call it, kind of moderate age related type 2 diabetes. And
Yeah.
what you see here is, so if we think about, essentially it's kind of a combined picture where their pancreatic function's not really elevated. So it's not like they're compensating all that much. So it's usually kind of the pancreas functions kind of in the normal range. Uh, and there's a little bit of insulin resistance. And so it's just kind of, whereas the severe insulin resistant,
Hmm.
have very high insulin resistance, very high beta
Yeah.
cell function, and it just slightly tipped out of balance. The weight related tend to have kind of this more, they've got they usually have elevated insulin, but not super high,
Yeah.
and they've got reasonably high insulin resistance. And then this age related, it's kind of like, yeah, the pancreas just doesn't compensate quite as well, and maybe that's an age function. And there's a bit of insulin resistance. Um, my personal kind of theory here, and just from experience with people here in this population, is um, the muscles are probably a little bit more important. And I think that part of what's happening is that um, as people age, we lose muscle bulk, and
Yeah.
muscles, as we talked about in the first podcast, incredibly important in terms of metabolic health. They're kind of our metabolic engine. So first, they store carbs that we eat. 80-90% of the carbs we eat will be stored in the muscle as glycogen. Then they also are burning fat. So in the background, they're what are, that's where the fat's going to get burnt from. It's going
Yeah.
to be the muscle burning it through. And then the third thing, which we didn't really talk about, was when you're active and using your muscle sends all sorts of signals around the body, and
Mm.
some of the signals they send go to the pancreas, and so pancreatic health is is often related. Like, so better pancreatic health comes from
From
exercise.
exercise. Interesting.
So so that population we kind of gear. We're often kind of looking at it from the standpoint of the exercise component's going to be important, and getting somebody with a moderate age-related type 2 diabetes to start doing resistance exercise is going to be super important.
Yeah. Cool. Yeah, it's always fun to see patients that come in and, like, they've been diagnosed type 2 diabetes, and they think that's the same for everyone. It's this unknown thing, and they come through and they do the consultation, go to the groups, get the reports and everything, and really understand so much more about what they have. It's really cool, and yeah, we discussed a lot about that today. But it's quite interesting how deep you can actually go if you really look into it.
Yeah, I think I think it's as a practitioner, as a physician doing this, one of the things that's really fun is actually being able to you know understand the physiology for this particular person, and so we get that from the lab work, but then we can look at kind of the symptoms that they're having, and you can
Hmm.
explain some of those symptoms on the basis of their physiology, and then we can also kind of align them around which behaviors are going to be the most impactful.
Yeah.
Because one of the things that we see in the program is we want people to get successful, right? So telling people to do 100 different things isn't going to work. What we need to
Yeah.
do is get them working on 2 or 3 things that'll be the most impactful things they can do right now,
Yeah.
um, and having the process and having the data that we have from the combination of our questionnaire process and our lab data gives us that kind of it's like the secret sauce to kind of get people started.
Yeah.
um, and then the motivation obviously comes from as they start to see, they start to make some changes. They start to see that, hey, they feel better, so some of the symptoms that they had are going away. They start to see their blood sugars go down. They start to see their weight go down, and they realize there is a path forward
Hmm.
here that can take
Yeah.
me away from kind of worsening chronic progressive type 2 diabetes towards remission, or towards just very well controlled type 2 diabetes.
Yeah. Definitely. It's very interesting. All right. Well, thank you for that explanation. We'll move on to some of our regular segments here on the show. So the first thing is our question of the week. So again, just a reminder for anyone listening, if you want to ask us a question for us to answer here on the show, you can go to the Lifestyle RX community. The links are in the show notes, wherever those are, and however you're watching, and leave a comment there, and we will pick 1 or 2 questions every week and answer them. So the question this week, I've heard this one quite a bit. It's one of the most common ones, I think. When I wake up in the morning, I like to have a cup of coffee with milk or cream in it. Does having the milk or cream in the coffee break my fast?
Yeah. So one of our core behaviors is at least having a 12-hour fast, and it fits with the body's kind of circadian rhythm, where we're designed to eat and be active during the daytime and rest and digest at nighttime. Glucose tends to be the default fuel for our bodies in the daytime period. Fat is actually our default fuel. So there's a metabolic switch that where we switch over and start burning more fat in the evening. But the fast gets broken anytime you have either protein or carbohydrate.
Hmm.
If you have fat, it doesn't get broken because you're burning fat, and consuming fat, you're going to continue to burn fat. So it's really kind of protein and carbohydrates that breaks the fast. Now, the, the $1 million question, and Jess and I, Jess, our lead dietitian, and I are always joking, that we need to do the study, how much milk is going to break the fast. What we
Yeah.
know is, if you have a latte in the morning, that's going to be enough milk, and the lactose, which is essentially a sugar, is going to clearly break your fast. if you have a tiny little splash of milk in your coffee, is that truly enough to break the fast? We don't know.
Yeah.
So kind of if we're being purists about it, what we'll say is, look, anything with protein or anything with carbohydrates will knock you out of your kind of
Hmm.
fasting physiology, and potentially stop the fat burning. So we don't recommend it. And if you really want to if you absolutely have to, then minimizing the amount that you put in your coffee is going to be the key thing.
Yeah.
Taking vitamins, isn't going to be an issue. Taking your medications isn't going to be an issue in terms of breaking the fast. You can have black coffee, you can have water, you can have green tea, you can have black tea. Again, it's
Hmm.
kind of what you put in it. So it really just comes back down to the is there protein or is there carbohydrates there?
Yeah. Okay. Cool. All right, and then we have once again this week a patient of the week case. So we'll play the video here, and then we can discuss it afterwards. This one I think is actually about one of the topics we talked today about the that autoimmune insulin deficiency, one of the subtypes that called LADA. So we'll play that now.
Hi, Dr. Brendan Byrne, Medical Director of Lifestyle RX here. Got a case study for you today. So, this case study is on something called LADA, and we'll get into that in a second. It's the story of JM. She's a patient that joined our program about 6 months ago. 67-year-old woman diagnosed in 2020 with a hemoglobin A1C as high as 8.5%. Now, JM's done really well in terms of changing things and has lost 30 pounds. So, by the time she presented to our program, she was on 2 medications, Jardiance and metformin. Her A1C was down to 7.2%, and her BMI was optimal at 19.9. Her goals were to reverse diabetes and get off medications. In our model, blood sugar control is determined by this balance between the pancreas's ability to produce insulin and the resistance that insulin faces in the cells. So pancreatic beta cell capacity versus insulin resistance determines blood sugar control. When we looked at this for JM, what we found was very little insulin resistance. There was really none to speak of at 1.16 times normal. Her pancreatic function was quite reduced at 42.1% of normal. And as a result, despite the medications, her A1C was still elevated at 7.2%. So essentially what JM has is pancreatic deficiency. Not insulin resistance, but pancreatic deficiency. 3 reasons that this can happen. One is long-standing diabetes. So for somebody that's had diabetes for many years, eventually the pancreas can lose its ability to produce insulin, and we will see pancreatic deficiency at the kind of end stage of type 2 diabetes. It could be genetic. Some people just don't make a lot of insulin. Or it could be this third process, latent autoimmune diabetes of adulthood. So this autoimmune insulin deficiency, or LADA, is one of the subtypes of type 2 diabetes. And what we see is severely decreased insulin release. And these patients are GAD antibody positive. In fact, that's how we figure out whether they've got LADA. We order the GAD antibodies to test for them. And 90% of the time in true LADA, that comes back positive. They often have normal BMI, so like JM, even optimal BMI, with minimal to no insulin resistance. And the hallmark of this insulin deficiency is it's really hard to tolerate carbs because you don't have a lot of insulin. And so what we have to do in our strategy is eat in such a way that we don't overwhelm the pancreas with a lot of carbohydrate that we don't have the insulin to store. So with pancreatic deficiency for JM, we can rule out longstanding diabetes because she's only recently diagnosed in the last few years. There wasn't any family history, and we tested her for the GAD antibodies, and they were positive. So we've got her diagnosis, latent autoimmune diabetes of adulthood, or really subtype 1 autoimmune insulin deficiency. So JM began the program learning the 4+2 strategy, and again, guided through our 12-week program and the 12 core behaviors. Now, normally the goal here is to achieve remission of type 2 diabetes, and that's really driven on the basis of reversing insulin resistance by losing the fat in the liver. Really, with JM, there is no visceral fat. She's at an optimal BMI. There's no measurable insulin resistance, so this doesn't really make sense. Instead, her goal became to achieve optimal blood sugar control with the minimal amount of medication. As she progressed in the program, her BMI remained the same. We weren't trying to lose weight. But she had a really nice progression in terms of her A1C, bringing it from 7.2% down to 6.2%. And really kind of what this shows is that, with patients who have this more recent onset of insulin deficiency, we definitely need to check for LADA. The 4+2 strategy can work here in terms of improving A1Cs, improving blood sugar control, but the goal changes from remission to control. Overall, patients with LADA can live this way for a long time with relative stability. So it's not always that their pancreas is going to completely lose its ability to produce insulin. It may just be that they're insulin deficient and stay, with low levels of insulin for many years. So with JM, what we're looking to do is create some stability, create some confidence for her that she can change the way she eats, maintain her blood sugars without having to add insulin to her regime.
Yeah, so that's a really cool example of one of the things we talked about today with that type of autoimmune insulin deficiency version of type 2 diabetes.
Yeah, we see probably, I think they estimate maybe 5 to 7% of people out there with type 2 diabetes actually have LADA. And so I think it's important to know, and I think the people that have gone through our program have benefited from knowing, and we tailor their strategy a little bit, a little bit more precisely.
Yeah, and it's also, at least in that example, cool to say that like those same strategies that worked for people with the other subtypes also causes significant improvement for this patient as well.
Yeah, absolutely.
Yeah. And just a reminder for everyone listening, you can watch the video there if you're listening to the audio only podcast. Head to the link and you can watch that video. It has, again, all of the graphics and stuff that are pretty cool to see along with it. Okay, and then we'll wrap up today with your thought of the week.
So this is something that we emphasize from the very beginning of the program, and it's really kind of the better mindset. So better done consistently gets results. Perfect done inconsistently gets you nowhere. And so we're constantly kind of helping people just understand better's the goal. We don't have to be perfect. Better can come in small steps, and better just be consistent with it.
Yeah, those small steps every day that get you to where you're going. Sure. All right. Well, thank you so much for listening. That's been our podcast for this week. Join us again next week for another episode, and follow us. Review, whatever the system is, wherever you're listening. Leave a like, something like that, to help the show grow. So yeah, once again, thank you so much for joining us, and we'll see you next week. Bye-bye.
Great. Bye.